Hey everyone, it's Dr. Dan Ritchie, president of the Functional Aging Institute, and I'm joined by my good friend Dr. Evan Osar. Evan and I actually were just in Indianapolis together at the Elite Fitness Performance Summit and the FAI Mastermind. Evan is based out of Chicago and has been on, I don't know how many webinars for FAI now, probably 3 or 4 at least. Always a popular presenter. He's been at Functional Aging Summit 2016 and 17 as a speaker, 2015 as an attendee, and then 2019 he was in Albuquerque, and he will be back in 2020 as well as his wife Janice. So
looking forward to it.
So Evan, I'm going to let you take it away. As always, attendees, pretty much we're going to let Evan speak for 35 to 45 minutes. But if you have a question you want me to interrupt, type it in the Q&A box. If it's something really pressing, I'll jump in, Evan. Otherwise, I'm going to let you talk, and then we'll do live Q&A at the end, okay?
Perfect. Awesome. Thank you so much. Thank you for joining us on this webinar. Thank you for having me. If you're listening to this live, I appreciate you giving up the time to be here with us. I promise to deliver a lot of great content to you. And if you're listening to the replay, hope you enjoy this and it helps your clients as well. And we're going to discuss knee issues, the 3 things you want to do pre and post rehab. And the reason why I say pre and post rehab is because to us, it's not really that different. What may change is what we do from a soft tissue standpoint. However, the strategy that we use with our clients, whether they are osteoarthritic and or pre-joint replacement and or after joint replacement, it's a very similar strategy. I'm going to share that strategy with you here in this webinar, so that way you have the main components of how we work with our own active aging population in our clinic. And I'll also give you an opportunity to further your education with a resource I created around this information. So I'm going to share a story with you. This is Lillian, and she's a client of Jackie and Jason in Houston, Texas. I was down there. Jackie and Jason are good friends of mine. I was down in Jackie and Jason's studio, Evolution Fitness and Wellness in Houston, Texas. They specialize in working with the over 50 population. And I was there consulting with Jackie and Jason. They paid for me to come down and consult with them in their studio. Lillian came up to me, and earlier this year, Jackie had paid for me to come down and do a talk for her trainers as well as for her clients. And Lillian was in attendance that evening when I gave my hour presentation. And she came up and said, I just want to say, I really enjoyed your presentation on the foot, and I really took home a lot of great information from the foot. Because Lillian's history, she had a history of falling and balance issues. She had been in physical therapy, and unfortunately, she was wiped out by Hurricane Harvey. Like, she had lost all her life savings, her and I believe her husband as well. And so she was not only having physical issues, but she was also having emotional issues, PTSD after Hurricane Harvey. So she had been referred to Jackie, and Jackie, the important component about this is that even though she was so grateful for the work that I shared with her and the work, more importantly, the work that Jackie and Jason were doing with her, she could actually walk without a cane. She had been on a cane, and now she was walking without a cane. So Jackie and Jason had done some really fantastic work with her. It was really about the community that Jackie and Jason were able to create and to support those individuals like Lillian who had lost her life savings. And that's really why this information is so important. Yes, we'll talk about knee issues and why that people get knee issues and things that you can do to help clients regain their confidence. But it's really about the community that you create with your clients. And you know that. So I just want to say thank you for all you do for your clients, because there's people out there just like Lillian that need to join your community and really be part of the movement that we're creating to help this active aging population. So our challenge is osteoarthritis is the #1 cause of disability in the world. Arthritis in general is, but osteoarthritis is the #1 category of arthritis. And we need to understand some certain things about osteoarthritis. And I'll share some of the information I'm writing about in my brand new book, Corrective Exercise Solutions 2.0, that's coming out next year. I've looked at the research around osteoarthritis, and I'll share some of that information with you in this presentation, because there's a lot of myths and fallacies around osteoarthritis. There's 7.2 million Americans with hip and or knee replacements. That's not counting individuals that have surgery for ACLs or meniscus or cartilage damage. That's just people having joint replacement. I should say living with joint replacements. And the age of individuals is going down, and more younger people are having joint replacements. Part of it is because the technology has gotten a little bit easier and it's more accessible now. However, it's just because people are wearing their knees out earlier. So we need to understand, why are so many people, young people, wearing their knees out? So we'll discuss that as well. 1 in 3 individuals over the age of 65 will fall. And Dan was just sharing this also last weekend during his talk at the Elite Fitness and Business Summit Performance Summit in Indy last weekend. Is like 1 in 4 of those individuals over the age of 65 that fall will die within a year due to complications, usually some kind of lung or congestive heart failure or something like that. But again, a lot of these individuals will fall not because of balance issues, but because of pain in their hip and or knee that causes them not to be so steady. So we can help, you can help a lot of these individuals by understanding this information and sharing it and using it with your clients. So there's 3 objectives of this webinar. Number 1, to discover the fundamentals and the 3 things you need to know about the knee. Number 2, to demonstrate 3 assessments and corrective exercises. And these are the things, like I said, you'll do pre and post rehab with your clients. And number 3, to develop you as the expert, because our goal here at the Institute for Integrative Health and Fitness Education, my wife and I created this company to support, educate, and empower health and fitness professionals just like you, so that way you can be the resource and be the expert in your area and attract more individuals that need, want, and will pay you for your expertise. So just one of the biggest things that I want you to understand is when you're working with clients, especially if they're pre and or post rehab, especially, I should say, right after a joint replacement, talk to the physician and or talk to the physical therapist. Probably the physical therapist will give you more information, but you have to get clearance and know what to do and what not to do with your specific client. And then you can use the information that I'll share with you in this webinar. So there's 3 things you need to know. The knee does 3 things. Number 1, gait. It helps us get from point A to point B. Number 2, shock absorption. Our knee is the biggest shock absorber in our body. So when we land, when we're walking, running, and or jumping, it becomes it is our biggest shock absorber, or most important shock absorber. 3, propulsion. It propels ourselves forward, our body forward, and or an object. If you're kicking an object, it'll also project things or propel things forward. Now, there's 3 things you need to know specifically about the hip, or I should say the knee joint. We've all learned that the knee is a hinge joint. That's great, except for the fact it's not a hinge joint. It's actually, it moves in 3 planes of motion. And this is very important because if you think of the knee, they used to do through their screws because the knee and the whole lower extremity needs to rotate. And that's an important part of the knee function. So the 3 planes of motion during pronation. Pronation is when the foot lands on the ground. This is very important to understand. So this gentleman, he's in pronation of his right leg, and he's competing at the Senior Games, which Dan's father, when we were in New Mexico earlier this year for the Functional Aging Summit, Dan's father was competing in the Senior Games out in New Mexico. So pronation of the knee is flexion, so the knee flexes. It abducts, so it actually goes more into slight valgus type position. That's what knee abduction is. It will also internally rotate. So if you can see my hands here, so imagine this is your femur, this is your tibia. The knee will flex, so this is flexion here. It will also abduct, so it will move more towards the midline this direction, and it will also internally rotate this direction if this was my right leg. So it'll flex, abduct, and also internally rotate. And that is important. Why is that important? Because it controls 3 to 7 times your body weight when you're running, for example. When you're walking, it's 2 to 3 times your body weight. When you're running, it's 3 to 7 times one's body weight coming down on that lower extremity. So you need to be able to absorb, I should say dissipate that shock. Pronation of the knee allows you to do that. When you have optimal alignment and control, it leads to optimal and efficient function. So you run, you can be active, your knees are healthy for life. This is a picture of my buddy, Steven. Steven is 63 or 4 years of age. He's the model for all my books. He has never had an orthopedic surgery. He's an epitome of what we want and what the body can do, even at 63 years of age. So I want to be just like Steven when I'm 63 years of age. Unfortunately, people like Steven are not coming to see you. So that's a challenge you and I have. Now, number 2, common issues around the knee. They often arise around the hip or ankle or foot. So what happens is we alter alignment around the hip or ankle and foot, which alters control, which creates non-optimal posture and movement. And we'll discuss some of those common things in a few moments. This becomes a self-perpetuating cycle. Another way of looking at this is really just your client's habits. It's the habits they've created over the course of their life, from anything from how they learn, the shoes they've worn, the activities they've done or not done, whether they've had injuries, surgeries, or traumas on their lower extremity. All those factors factor into why someone or how someone creates specific habits. So we want the femur and tibia to be relatively well aligned. So you see the picture on the left of your screen is more optimal alignment, where the femur and tibia sit on top of each other like they should. Now, many times your client will have non-optimal alignment and control, which starts to create what we refer to as wear and tear. And that's essentially what osteoarthritis or degenerative joint disease is. Unfortunately, those are not great terms, because osteoarthritis sort of signifies that there's an arthritic process happening, whereas degenerative joint disease sounds like it's something that just is going to happen to you or something you may catch from somebody else. Neither of these are true, obviously. So here's what we've termed the degenerative joint process, because that's what it is. It's a process that leads to the wear and tear, and ultimately why some of your clients need knee replacements. First, you change alignment and control. Alignment is just a relationship of the femur and tibia and the entire lower extremity. And control is how your nervous system controls that knee during pronation and functional activities of everyday life and sport and occupation. Alignment and control issues lead to soft tissue changes. So the first thing that starts changing is you start changing your alignment and control, and then you start changing soft tissue. Some muscles get overstretched, others become short and tight. Ligaments, same thing. Some become overstretched, others become short and tight. The meniscus starts changing. It starts to become more fragile and maybe even have tears. The cartilage starts to wear down. So we start to change the soft tissue structures around the knee. That's oftentimes the early signs of degenerative joint disease, or what we've referred to earlier as degenerative joint disease. Finally, you get bony changes. Why is your client's knee so much thicker and bigger when just prior to needing a knee replacement? It's because the body knows that it's not very stable, so it's lying down. It's laying down more bone to create more stability. That decreases the joint space, that increases the likelihood of alignment and control issues. So again, it becomes a self-perpetuating cycle. Bony changes is also known as, you've probably heard of Wolff's Law. Wolff's Law states a bone under stress will remodel. It's just really Wolff's Law. The body's laying down more bone to make that bone more dense. And then, like I said, it just becomes a self-perpetuating cycle. So we often hear that, isn't it just genetics? My mom had bad knees and so do I. So this is a study that came out of the, I'm sorry, I forget which journal it comes out of, but this researcher, Dr. Wallace, is out of Harvard. So he and his colleagues looked at skeletons pre-1900 and after 1900. So before the Industrial Revolution and after the Industrial Revolution. So this is what he came up with. He said, our analysis therefore indicate that although knee osteoarthritis prevalence has increased over time, today's high levels of the disease are not, as commonly assumed, simply an inevitable consequence of people living longer. So if it's not that, what is it? Dr. Wallace thinks the most obvious candidate to explain the increase in knee osteoarthritis in the last 100 years is a modern decline in physical activity. And I want you, if you're taking notes, hopefully you are taking notes, please write this down. I believe it's not just the decrease in overall physical activity, so it's not just the quantity of exercise, it's also the quality. Our quality of exercise has gone down because the quality of our posture and movement has gone down. So we need quantity. Our clients need more quantity, but they also need more quality movement as well. So I love this quote by Dr. Caldwell Esselstyn. I believe he's out of the Cleveland Clinic in Ohio. He says, your genetics loads the gun, your lifestyle pulls the trigger. And when we talk about knee osteoarthritis or the degenerative joint process that leads to knee osteoarthritis, it's really just that. You have a certain genetic code. All your clients have a certain genetic code for how well they develop and build cartilage and how dense their joint capsules are and how well their motor control is. However, your lifestyle, their lifestyle will dictate how well that functions or how well that doesn't function. So this is what you really want to empower your clients with, is they can take control, that it's not their genetics that's leading to this issue. Again, if they do have rheumatoid arthritis or psoriatic arthritis, those are sort of genetic conditions. So that's a different sort of set of categories. We're talking pure osteoarthritis that is all about an individual's lifestyle and their habits. So the number one cause of knee problems is the habits. And I love this cartoon, or I should say this picture, because It says, conquer your bad habits or they will conquer you. And that's why your mom told you not to pick your nose, because it's your habit. If that becomes your habit, that's what you do as an adult. So let me show you a habit that commonly causes knee problems. This is my client. She is I should say she was a runner. She's no longer a runner because she's got too much knee pain. You can see the difference in her kneecap position. This is one of the assessments we'll talk about in a few moments. You see the right kneecap is facing relatively straight forward and the left kneecap is facing inward. Now, we never base anything on posture alone. When you come through our certification course, the Integrative Corrective Exercise Instructor Program, we teach you how to assess, and we do talk about posture. However, you never base anything on posture alone. Posture is just a starting position. So you want to see what is a starting position and then what happens when your client loads, when they put their joint under load. Does that get better? Does that position get better, or does it get worse? So you tell me what happens when we go into single leg stance, when she goes into single leg stance. Does that alignment get better or worse? And you see, obviously, it gets worse. So she goes more into internal rotation and knee abduction. She goes more into unleveling of the pelvis. So the strategy is not getting better, it's actually getting worse. So her posture strategy is leading into her loading strategy. And what happens when this client goes into run? More of the same. And remember, this is 3 to 7 times the body weight coming through the knee. So you have 3 to 7 times body weight coming through that knee that's not optimally aligned or controlled. That's why running bothers people's knees. There's a study that came out recently that says running has zero impact on osteoarthritis and does not cause osteoarthritis. In fact, it tends to be healthy, it appears to be healthy for the knees. But you have to kind of read the whole study, because if you look at the last line, the last paragraph of the study, here's what it essentially says. It says that in people without prior osteoarthritic changes, running does not appear to impact the knees. So I want you to think about your clients, because if you just read the title or the caption, or I should say the summary of the study, it'll say, hey, running is actually healthy for the knees. But you have to read the whole study. And I want you to think about your clients. How many of your clients are actually aligning and controlling their knees and therefore should be running? Because I would agree, if your client has optimal alignment and control of their knees, yeah, running is probably pretty healthy for their knees. It's like any kind of exercise and activity. However, if your client is loading up her knee like this or like this, I'm going to tell you right now, running is not good for her knees, and running will just hasten the pace to osteoarthritic change. I see it every single day in my practice. Don't let people start to tell you that running is great for your clients' knees because some study showed that it has no impact, because that's not true. It's not looking at the complete picture of the client that's sitting in front of you. Okay, so optimal function, when you have optimal alignment, breathing control, the individual can align and control their hip, knee, ankle, and foot, and that's a picture of a very well controlled hip, knee, ankle, and foot. However, like I said, most of our clients are not controlling that way. And that's why there's such a difference when you watch the people that win marathons or win these elite races. I'm not discrediting anybody that finishes a marathon, because I have mad respect for people that finish marathons, because I know I cannot do that. However, if you think about running a marathon on that knee and running a marathon on that knee, which one would you choose? 100 times out of 100 times, 100 times out of 100 times, I would run with that knee, because I know that that is not going to be great over the course of one's life. You will break down, you will change your body structure because of this alignment and control. So one of the common issues, and what you're really seeing, let me back up for a second, what you're really seeing in this picture here is this issue right here. There's internal rotation of the femur and relative external rotation of the tibia. So don't worry about the words if that gets you all confused. Just know that your femur, the client's femur, is going in and the tibia is relatively going out. The femur could be straightforward, but the tibia is going out. It's still relatively internal rotation of the femur relative to external rotation of the tibia. This is the most common issue of the knee, and very few people actually talk about this relationship. So you're going to help so many clients with knee issues because you're going to be one of the few people that actually talk to your client about this issue. You don't mention these words, you just tell them that your knee's all screwed up, we're going to help you straighten it out. So this is a client that also has big toe issues and knee issues. She wants to walk and run for exercise, and you see this is a common issue. You'll see that she's actually on the outside of her foot, and you see the popliteal fossa, this fossa right back here, should be facing straight back at you if you're looking at her in a standing position. You can see here in standing, it's rotated out. So that means that her femur, again, rotated in, tibia is relatively rotated out. But again, remember I said we never base anything on posture alone. So let's see what happens when she stands on one leg. So we have her stand on one leg. Does that get better or worse? And obviously it gets worse both sides, but you see the left side, it's relatively well controlled. But on the right side, you just see her spin that knee and again, go on the outside of her foot. And that's why she keeps pushing and overloading her big toe. And that's a very common cause also of your clients that have bunion issues, okay? So that's essentially some of the strategy that led to bunions as well. So knee issues are also becoming foot issues. Now, let's talk about the foot because like I said, as Lillian came up to us and talked to us after, or in the gym, she mentioned that the footwork that I shared with them was very, very powerful. Now, this is the 3 things that you need to know about the foot. And again, very simple. Number 1, you need to know that the foot should stay on the foot tripod. Most of the weight of the foot should be underneath the big toe, small toe, and heel. And if you actually looked at the feet of your clients, I do this all the time. You may not have your clients take their shoes off, but you're going to notice that their calluses really aren't underneath their big toe where it should be. It's actually right here underneath digit number 2. That's a common cause of again, bunions. It's a common cause of neuromas and all kinds of other foot issues because they're not supporting their foot properly upon the foot tripod. So number 1, foot should be on the foot tripod during most activities, except for when you're pushing off. Then it goes on to just these 2 points. But the rest of the time, when you're squatting, lunging, stepping, your foot should be on the foot tripod. Your client's foot should be upon the foot tripod. So that's number 1. Number 2 is your foot should get wider as you load. So when you squat down, your foot should get wider and slightly longer. That's just the normal biomechanics that allows your foot to react to the ground. You don't want the foot to collapse in. So if this is my right foot, you don't want the foot collapsing in. You want it to spread out and get wider and remain upon that tripod. So tripod is number 1, wider and longer, number 2 and 3. This should happen anytime your client loads a foot. And I'll show you a very simple way to get better activity of the foot. So that way you align the foot better, which helps to align the knee better. So that's how the foot relates up to what's happening at the knee. Because when your client has a stiff foot, they're going to roll in like this client right here is doing. This is not a flat foot or collapsed foot. This is a high rigid foot. And what the client is doing is they're dumping their foot in because they don't have the ability to go longer and wider. And that's what starts to overload the knee because now your knee has to start rotating to make up for the lack of foot motion. So that's your clients that have rigid, stiff feet. And if you look at the feet of many of your clients, some of them are really flat for sure, but some of them are actually claw-toed and rigid. They don't have a lot of motion of their foot, and that's why they go claw-toe. And that's why towel curls and all those crazy exercises that PTs have their clients do are actually not great exercises because all they do is keep training the long toe flexors. So they're all a better exercise for a lot of your older clients is to get them to spread their toes out and get more upon their foot tripod. I'll give you an example of how to do that in a moment. This is a client that actually does, or has, I should say, collapsed down through their medial arch. And you see their navicular bone, that bone that I'm circling right there. Hopefully you can see the arrow there, just below the medial malleolus there. The navicular bone is upon the floor, and you see the navicular bone here on my client upon the floor. That's when you have collapsed that client or individual has collapsed that entire arch, and that will also create knee issues above. Now, the flat foot 100% of the time is not the problem, however. Here's 2 examples. This is a collapsed arch. This person does need orthotics. They've just collapsed the arch. I would still train them in bare feet at some point to see if they can actually develop control of that medial arch. Many of them can. However, most of these clients will need orthotics during the day. This client has a flat foot as well, but you can see he has equal pressure, big toe, small toe, and if you can see his pinky toe, he's have equal pressure on his foot tripod. That's a well-controlled. He just has smaller arches. In fact, if you look at most native people's feet, their arches are lower. It's we in the Western world that have high arch, rigid type, narrow feet. If you look at the native foot, it's much wider and the arches are much flatter. So this is actually more what the foot actually should look like. Okay, review time. The primary cause of knee problems is your client's habits. It's some non-optimal and inefficient habits they developed over the course of their life. They've developed these non-optimal alignment and control that causes the knee to have to compensate or the ankle and foot to have to compensate, and then you just get perpetuation of these issues. Now, let's talk about what we're going to do about it. The integrative movement system is what we use with our own clients in our clinic. First, we assess to determine and identify our clients' non-optimal and inefficient posture and movement habits. Then we address it with corrective exercises, and then we integrate it into the fundamental movement patterns. It's a very simple 3-step process. I'm going to take you through that process so you can see how to integrate it directly into the programs that you're already using with success. First, assessment. Remember, the posture is just a starting point. What we want to do is look at the kneecaps. The kneecaps should be facing straight forward, and you can see this client's kneecap straight forward. This one's turned in, even though her feet are straight. Some of your clients, their kneecaps will both be straight forward, but the foot will be turned out. It's the same thing, that femur internal rotation, tibia external rotation, and you can see it further, or I should say easier, from behind. The popliteal fossa should be facing straight forward, and this one is significantly rotated in, as is the left side. Actually, I should say the left side is more significant than the right side. You can kind of see more of her toes over here on the left side, and that relates to what you see over here on her left side as well. The weight should be on the foot tripod on both feet as well. And it's hard to see in this picture, but she's actually on the outside of her foot a little bit more on this left side. Okay, now, second assessment is single leg stance. So you want to see what happens when your client stands on single leg, because that's essentially walking. It's transition from 2-leg support, bilateral support, to single leg support. And you can see the client is not controlling her pelvis very well. And you see that internal rotation of the femur and relative external rotation of the tibia. Here's my friend Jackie's client. She's got hip and knee problems, and you can see why. She's not really controlling her weight on either side. Okay. So we want to see that the client is able to stand and control her weight over top her foot when she stands on single leg stance. So this is a client of mine. She's a younger client, but she has lateral knee pain and iliotibial band syndrome, a very common issue with walkers and runners. So I want you to look at her weight shift. Don't worry about looking at all the mechanics, but just look at what leg looks like she has to shift a little bit more to stand on. Which side looks like it's a little bit harder to stand on, or she has to shift her weight a little bit further to stand on? And if you look, left side, not so bad, but right side, I'll play it one more time. Look how far she has to shift her weight onto her right side, and that's the side with the iliotibial band problems and lateral knee pain. And if you look at her knee, I'm going to stop this one as soon as she gets back on her right leg. Oops, let me play it one more time. Stop right there. And again, you see the same rotation through her knee, internal rotation of the femur, external rotation of the tibia. It's the most common pattern that very few people talk about, and you'll be able to address it with your clients once I get to the exercises. The third assessment is just have your clients sit on an elevated surface so you can see where their tibias are aligned. Ideally, the femur and tibia should be aligned on top of each other. You see in this client with knee pain, you see your tibia is externally rotated. And this is so often why you see this appearance when your client is squatting. You see the tibia externally rotating because it's making up for something that's happening either up at the hip and or down here at the foot and ankle. Usually this is an issue down at the foot and ankle, and I'll show you how to address that in a few moments. Okay, so you've done your assessments. That's not all the assessments you'll do, but those are very powerful 3 assessments that you can do with your clients. Now you figure out your clients' habits. Now we need to go into our corrective exercises to address those habits. Now we have to know what's short and tight and what's over lengthened and weak that you actually need to improve. So short and tight muscles are the iliotibial band. That's a structure, obviously, the lateral hamstring and the lateral gastrocnemius and soleus. Those are the muscles that are pulling the tibia into external rotation and or the femur into internal rotation. Now, those muscles are short and tight, so there's muscles that are over lengthened. Popliteus, the muscle that goes across the back of your knee, the medial hamstrings, and the medial gastrocnemius and soleus. So those are the muscles that we'll need to activate and get them more active. So the first thing you need to do is myofascial release. So we're going to release superficial glutes that attach into your IT band. That's why we're releasing them. Most of your clients, especially your older clients, they're in posterior pelvic tilt. They need that posterior pelvic area, those muscles, posterior glutes, I should say glute max, posterior fibers of glute medius, the external hip rotators, they need those muscles released because they're stuck in posterior pelvic tilt. Why are so many clients, older clients, stuck in posterior pelvic tilt? One reason, I should say 2 reasons. First reason, spinal stenosis. Almost all your older clients have some level of spinal stenosis. The way you create better or more space in the spinal canal is to go into posterior pelvic tilt. So none of your clients, older clients, are in anterior pelvic tilt. There's no possible way that they'll be in anterior pelvic tilt, so don't buy the hype that they're in anterior pelvic tilt. They're in posterior pelvic tilt, and the second reason they're in posterior pelvic tilt is because they sit. They sit most of their day, and they've sat most of their life. So sitting puts you in posterior pelvic tilt, not anterior pelvic tilt. So you have to release that posterior hip complex. You have to release the lateral hamstrings and gastroc and the posterior tibialis and the foot. And you'll do that through your myofascial work. You can use a ball. We'll use a little activator from Rolga. You can use Yamana, that device if you're familiar with that device. But again, use whatever tools you have. When your clients are rolling their ball on the foot, don't have them just roll it like this. Have them sink in, hold, then move it, sink in, hold, then move it, sink in, hold, and then move it. So that way it becomes much more deliberate, and you really start to wake up those proprioceptors of the foot and the ankle complex. Now, the second thing you have to work on, this is actually our first corrective exercise, is lying ball curl. So I'm now moving into, once you've done your release work, you have to move into the 3 most effective corrective exercises. And again, this is pre and post rehab. Whether your clients have osteoarthritic knees and or joint replacements, these are the 3 exercises that we go to the most. Lying ball curl is an exercise we came up with because what we needed to do is get our clients to internally rotate their tibias and externally rotate the femurs. Because remember, the femur, this is my right side, has gone internal and the tibia has relatively gone external. We need the exact opposite. We need internal rotation of the tibia and external rotation of the femur. This is the best way we found to impact that alignment. So we place a yoga block between the tibias just to keep the tibias vertical. They don't move, but what will move are the knees. The client will push their heels down into the ball and they'll pull the knees into the chest, moving just at the hip joint and the knee joint. Let me show you, I'll cue this up so you see what that looks like. So the yoga block is lengthwise between the tibia to keep the tibia steady. And now you'll push the heels into the ball, and it's a small motion. You don't need to go very far. The goal is to get the tibias to better align and then the femurs to come into that external and abducted position. Because if you think about this position I'm in right here, if I put myself upright, which position am I actually in? It's basically the squat position or the hip hinge position. So that's why this position works so effectively for so many clients. It's our go-to exercise. If you do your releases well, which you will, and then you add this exercise, many of your clients can really, really change that alignment of their lower extremity. Don't force it. Don't have them squeeze as hard as they can. The knees have to be wider than the feet, and it's just a small motion pulling their legs forward on the ball. If our clients go home with this exercise, we just have them put their legs up on the coffee table or chair and just do the leg slide just like that, just keeping the feet straight forward towards the ceiling and the knees slightly wider than their feet. Now, your second of your corrective exercises are your hip hinge bridges. Now, here's how most of your clients are doing their hip hinges, or I should say their bridges. They're using their quads, and they're pushing their body back towards their head. That's why you see their head moving, or they're over squeezing their glutes and their back, and they're just thrusting their back. And you see my face there. You're like, what the heck's going on there? That's a terrible way to bridge, and you're just reinforcing, re-perpetuating the habit your client is already in. So here's what you have to do. Now, if you look at the length of my tibia, I got pretty long, scrawny tibias. So I have some space, and my butt's not so big. So I have some space to move my hips. But most of your clients, when you think about your older female clients, and it's not to be derogatory, but they have very short tibias and bigger butts, right? Or wider glutes, bigger mass back there. They don't have very much room to move. So they have to overarch their back to actually get their butt off the floor. So you have to elevate their feet to give them more range to work with. Because ultimately what you're trying to do with a hip hinge bridge, and this is why we call it hip hinge bridge, is to move and hinge at the hips, not to do posterior pelvic tilt, not to do lumbar spine flexion, not to over squeeze the glutes, but to use their glutes and to create a hip hinge around the hips. So here's how we set our clients up for that. So I'm going to make sure my head and neck and thoracopelvic cylinder is aligned, and you see me checking my low back. I'm not trying to flatten my low back down upon the floor. I'll place my feet up on a chair or a stack of steps. And then when I go up, my weight stays down towards my feet, and as I come down, I flex my hips and do my hip hinge. So I'm not changing the pelvis or low back position. I'm doing a pure hip hinge as I do my bridge. It's way more effective than the bridge up above here. It's way more effective than 95% of people that are doing bridges and hip thrusters and all those crazy exercises. You want to create a hip hinge motion, a hip flexion and hip extension, and not overgrip the hips, because that's will just drive your clients back into posterior pelvic tilt, which then rotates your femurs, and that will create more of those knee issues. You want to teach your clients how to use their hips appropriately. Okay, so you got your first exercise is the lying hip activation pattern, the ball slides. Number 2 is your hip hinge bridge. Number 3 is probably the most important of all 3 of them, and that's your hip hinge. And this is what you need to do before you do your hip hinge. You need your client to align their pelvis and lower extremity. You want the pelvis square up to the lower extremities. You want the foot tripod. You want to make sure the toes stay long upon the floor. Now, this is how we set up our hip hinge. And the reason I put 3 stars next to this is the number 2 pattern you should have your clients do. There's 2 exercises that will change your client's life. Number 1 is breathing. Next week, I should say next month, I believe Janice is going to be on a webinar here talking about breathing. Breathing is the number 1 thing that can change your client's life, and I am not exaggerating that. Janice will discuss why that and how that is so important to your clients. Number 2 pattern that can change your client's life is the hip hinge. And I want you to watch how I perform this pattern. It's very specific how we set our clients up and how we perform this pattern. We always start with the head and neck and thorax aligned over top the feet, and then hands go upon the pelvis, and then it's an anterior pelvic rotation. If you notice, I'm not shoving my pelvis back. I'm rotating my entire pelvis and thoracopelvic cylinder, my cylinder, over top my femoral heads. It's not shoving the hips back, because I'm going to show you what happens when you shove your client's hips back. You have to teach them how to anteriorly rotate the pelvis, because that's going to overload, I should say appropriately load, and help them optimally use their glutes, hip rotators, and hamstrings. Let me play that one more time, get a sense of the alignment and the control. And then I'm going to put my hands on my pelvis, and then it's anterior pelvic rotation. It's not shoving the hips back. It's getting the pelvis to rotate over top the femoral heads, and that's why you need to release the posterior hip complex so that they can effectively rotate the entire cylinder over top the hip joint itself, the femoral heads. Because here's what your clients will do when they're unable to do that right there. So let me turn the volume down. Let me get the screen out of the way. Let me see if I can get my face out of the way there. This is a client that has short, tight posterior hip complex. So short, tight hip rotators, glutes, and hamstrings. And this is what a lot of your older clients will do, the exact same thing as my client is doing right here, is when she goes to bend forward, you're going to see her shift her pelvis, but you will not see her get anterior pelvic rotation. So she's going to slide her arms down her thighs, and watch what happens as she's bending forward. You see the big shifts. That is not anterior pelvic tilt. That is just posterior weight shifting, because she's not getting anterior pelvic rotation. So that's why the anterior pelvic rotation is so important for all your clients, especially your older clients, because when they get that, they load up the posterior hip complex. They take stress off their low back, they take stress off their knees, and they learn how to hip flex, which is needed for almost every single functional lower extremity pattern. You're squatting, you're lunging, you're stepping, sitting all day long. You want them to be able to hip flex and anterior pelvic rotate so they can actually sit on their sit bones and not sit in posterior pelvic tilt. This is what your clients are doing, and you can see my client here. She's already starting that process, and she's a lot younger than a lot of your clients. So that's a lack of anterior pelvic rotation because of posterior hip and hamstring tightness. That's why you need to release here first before you have your clients do these corrective exercises. So that's the second most important exercise after breathing, but this is the third exercise you'll do for your clients that have knee issues. Now, you've done your assessment, you've done your corrective exercises. Now you have to integrate this new function into the fundamental movement patterns for the lower extremities. The squatting, the lunging, the bending, the pushing, pulling, walking, carrying, and balance patterns. Now you can think about your lower extremity patterns as either hip dominant or knee dominant. I don't like this categorization. However, hip dominant patterns means you're not bending your knees. Knee dominant patterns means those patterns where you are bending your knees. If you have clients that have chronic knee issues and they have painful knees, oftentimes the strategy that I just gave you will allow them to do these patterns over here with no problems. However, you'll have clients, their knees are just so shot by the time you see them, or by the time they get to you, you need them to do hip dominant, wrong way. You need them to do hip dominant patterns. It's just not worth loading their knees and causing problems, because then they're angry and frustrated that you just cause their knees to be more painful. Have them do the bridges, the hip hinges, the stiff-legged deadlifts, which is basically just a loaded hip hinge. Have them do those patterns, because they can still get the foot tripod. They can still get alignment of the hip, knee, ankle, and foot complex. They can still get loading of the posterior hip complex without overloading their knees. So, in recap, your success for your clients is taking the functional training model that you're already aware of as a member of FAI, adding the integrative movement system to it, the proprietary 3-step process. Assess your clients to identify their non-optimal and inefficient posture and movement habits. Then you use your corrective exercises in phase 2, the address phase, where you use your corrective exercises to help your client create more optimal and efficient habits. And then in phase 3, the integration phase, you integrate these more optimal habits into the fundamental movement patterns that your client is most successful in doing. And this is a very seamless model. It can be plugged right into the programs that you're already using with success. Be the expert, empower your clients to move better, to perform better, and feel better, and be at their best. Your clients need that. They want it, and they're looking for an expert just like you. If you're looking for more information, hopefully you've taken a lot from this webinar already. We created the Complete Knee, Ankle, and Foot Conditioning 2.0 product. It's 6 hours of online content covering the anatomy, biomechanics, motor control. I gave you a sense of that today, but we go way more in depth in this 6 hours of online content. I go through all the assessments that we use with our clients, common issues. We talked about some of them in this webinar as well. We go through all the corrective exercises around the knee and ankle and foot. And we also take you into the functional exercises and how to integrate this into your functional exercises. Now, I also created a couple bonuses, and the bonuses alone are really worth the price of this course. And I'm not exaggerating that, because in the bonus, the first bonus, I gave you a quick start manual, the 7 principles that discuss how do you set up the lower extremity in your clients. They're 3 to 8 minute videos, and to help you master the fundamentals. How do you align? How does the body actually work? What is pronation? How do you help your clients identify pronation? How do you identify pronation? How do you help your clients understand this concept in simple and easy to learn tools? I give you the 5 assessments that we talked about in here. I should say I gave you 3. I'll give you another 2 in the bonus assessments. It's again, super easy for you to look at and see these things going on in my client, because she actually has knee issues. Posture, single leg stance, squat, lying assessment, and seated assessment. I'm going to show you the 7 most effective corrective exercises for the knee, ankle, and foot. And these are the exercises, like I said, I showed you 3 of them today. One is the bridge, one is the lying ball curl, and one is the hip hinge. I'll show you those exercises and 4 additional ones that we use most commonly with our clients with knee, ankle, and foot issues. I'll talk about the short foot, why the short foot is not always appropriate for all your clients. I'll show you how to set up the foot tripod, how to get the client using their foot in a more effective manner. The same thing I did with Jackie's clients down in her studio. The 7 exercises you most want to modify and or avoid, I talked about one of them already. That's a bridge pattern. You should not have your clients bridging on the floor, especially your older clients with short tibias and wider butts. You need to have their feet elevated so they have range of motion. You do not want them going into posterior pelvic tilt and lumbar spine flexion. You want them doing a pure hip hinge bridge. I'll talk about 6 other exercises like the squats and other exercises that you need to modify and or avoid with your clients that have knee problems. And the bonus 5 is bonus that most people ask for. How do I plug this into my programs? What does it look like to put these corrective exercises with my programs? So I made it super easy. It's really just plug and play. Take these exercises, do these things, plug it into your program. I share with you Linda's program. Linda is a client of mine. I had some pictures of her earlier in this presentation. This is her exact program that I use with her to get her from having chronic knee and ankle issues. This is the exact program that I use with her. So you'll see exactly how I put this together so you can use it as a template for your own clients. So you get 6 hours of online webinar and video content. You get the 5 bonuses. Like I said, the 5 bonuses alone are worth the price of this program. The package is valued at over $500 for you guys today. As FAI community members, it's $147. Dan will provide you with a link for that. And that's all I have for you for today. Hopefully you've taken a lot from this webinar and you can use this information. I've given you some information that you can plug right into the programs right away that you're already using. And even though it seems simple, please use the information. Take one of your best clients. Don't start with your clients that have knee problems. Start with your clients that don't have issues so you get comfortable using this information. Play with it with yourself, on yourself first, so you know how it feels and how to describe the exercises to your clients, and then start playing with some of your clients, using it with some of your clients that do have knee issues, as long as they've been cleared to exercise and they don't have any like crazy chronic issues that you're dealing with, and you're going to see a lot of changes with your clients. I'm going to stop my share and send this back over to Dan, and we'll take questions because we have about 10 minutes to take questions.
Thanks so much. Great stuff. I've already got a question here. So those of you still on live, we'll see how many questions Evan can take here in 12 minutes. Joe asked, what can you suggest as an exercise path for a client or friend who has osteoarthritis, bad knees, but has also been a lifetime marathon runner, runs for sanity, Joe says.
Yeah. So I just had a client come in yesterday. She's the same kind of client. She's 72 years of age. She doesn't run. She's not sane. She's got a high stress job. She's a professor, of her department at U of C here. So you have to give them corrective exercises. They have to have a routine that they do before they run, and they also have to come back and do a routine after they run. A lot of the exercises, or I should say a few of the exercises that we covered in this webinar are some of the exercises that I will share with my clients and have them do, but have them check in before they run, do their correctives, their release work, as well as some activation work. The footwork is very important. Their breathing work, like I said, Janice, I believe, will be on next month talking about breathing. Every client, every runner has to breathe. They have to learn how to stack their cylinder, and then they have to do some work after they run to help, because they're going to get tight, especially if they have chronic knee issues. They have to do work after, and that can really help a lot of your clients because they just want to run. They don't want to do the pre and post work, so that can be very beneficial for your clients that need to run and also have bad knees.
Okay, great. Francesca asked, once you pay for the program, how long do you have access to it?
Lifetime. You have, as long as we exist as a company, which we plan to be around for a long time, you have access to the program. It's all online. So as soon as you get access to it, it's yours. It's online. You get direct access. Dan will send out that link later on. It's yours forever.
Okay. Question on spinal stenosis. Could you review what you said to do with reference to spinal stenosis?
Yeah, spinal stenosis is a huge issue. And this is what, and again, I'm not trying to bash anybody, but this is what a lot of fitness professionals don't understand when they're trying to teach you who work with the older population about low back and hips. Most of our industry is teaching to over squeeze and over contract the glutes, and it's driving people into more posterior pelvic tilt. Your clients are already in posterior pelvic tilt because of spinal stenosis. So spinal stenosis is a condition which is now where the spinal cord is, or where the nerves are coming out of the low back and down the leg, or even out of your neck and down your upper extremity. All older clients have some level of spinal stenosis. The clients that are seeing you and I, they have more advanced degrees of spinal stenosis, because the ones that don't have a lot of spinal stenosis, they're good. They're not seeing you and I. So what the body will do is it will put itself in posterior pelvic tilt and flex the lumbar spine in order to create more space. So posterior pelvic tilt and lumbar spine flexion creates more space in the spinal canal. But in that process, it shortens down your external hip rotators, your posterior glutes, and your hamstrings, the hamstrings of these clients. That inhibits them from getting into what we need them to get into, which is anterior pelvic rotation to do a proper hip hinge and squat and lunge. Then their knees pay the price for that. And that's why almost all your clients that have knee problems have spinal stenosis. Your clients that have spinal stenosis will develop knee problems, because these two things go hand in hand. What you want to do with your client is release that posterior hip complex and not change their pelvis, but that will allow them to get that anterior pelvic rotation. But it's a whole body. It's not just a pelvis rotating forward. It's a whole torso. The whole cylinder rotates forward, and that's what allows you to load the hips appropriately and still not overstress the spine and take stress off those knees as well. Hopefully that made sense.
Yeah, yeah. They're asking a follow-up question. Over what
Yep.
period of time do you expect to see that improvement? I mean, like how fast, how long,
It
how long?
should go very fast. Now, it won't always go super fast, but if you do the right releases and you really educate your client and they go home and practice it. So one way, I didn't show it in this video, but one thing we'll have our clients do is they'll put their butt up against the wall. They'll put their hands on their pelvis, and then I'll have them focus on sliding their tailbone up the wall. So that way they have some guide of what anterior pelvic tilt actually feels like. So try that with your client. That actually can be very effective for getting them, because it can change. Again, they're not going to look like what I look like, but they can change from like no anterior pelvic tilt to some anterior pelvic tilt. And that's all you're trying to do. Just give them a little bit of anterior pelvic tilt so they understand how to move their pelvis appropriately.
Okay. Martha says, thank you for the wonderful presentation. How many credits does your course provide?
I don't know, because Janice takes care of that. So let me check with her. I'll have her get back to you, or somebody from our company will get back to you. I just want to make sure that it is approved. I believe it is approved. Obviously, you'll get CECs from FAI, but I'll have somebody follow up with how many ACE and AFA CECs.
Yeah, Martha will get you a direct email on that. I can't remember. Celia probably knows too if it's 6 or 8 hours.
Got it. I think it'll probably be 6, but I'll just confirm before I say anything.
Yeah.
Sure.
Okay. All right. I got one more question, folks. If you still want to ask a question, last chance. Do you have use, or do you see use for functional orthotics in conjunction with this treatment?
I refer people out because one thing I want to focus on, what I focus on. Orthotics is a whole nother bag of stuff that you have to sort of deal with. So send them to develop a relationship with a local podiatrist or chiropractor. The only thing I'm going to caution you on, and this is sort of controversial as well. I'm going to upset a lot of people, and this is Emily Spickle. She knows her stuff, so I'm not talking about her. But there's a lot of podiatrists and chiropractors that are giving orthotics that don't know enough about ankle and foot function to be giving orthotics. So unfortunately, you have to do your due diligence and find somebody in your area that you trust and like. I don't have a lot of people even in my area. I found someone that I do trust that I can refer to down the street. So I'm lucky, and I know enough to tell my clients whether they need them or not. So find somebody in your area, do your due diligence. Like I said, somebody that has a high arch rigid foot, they may not need orthotics. They may need to learn actually how to use their foot better. The client that has a collapsed arch, they probably need orthotics. So again, that will definitely be a referral. But like I said, find somebody in your area that you can refer to and establish a relationship with, because you should be working with those clients. They should be referring you clients as well for work after they've either gotten orthotics, or maybe clients that don't need orthotics that just need someone like you to teach them this information. That was a really great question. So thank you for all the questions, because that's sort of a controversial question that
Sure.
Yeah.
Katina is asking, when will you be back in Florida? I assume she's asking this of you, not me. But
we will be back in Florida, I believe, next sometime, April, May, or either April, May, or August. Definitely August, but maybe earlier than that. But if the Functional Aging Summit next year is in Denver, so we will not be there for the Functional Aging Summit.
No, for sure. I will be in Florida, in Orlando, in November. So sounds like I'll beat you to it.
You will.
Francesca, follow-up question. How many times a week should clients do these exercises as homework if you only see someone twice a week?
Every day. When somebody else asked that, I'm not sure if it was her, asked that question, how long does this process take? If your clients do their homework, you can see changes by the time they come back next week. If you see them twice and they go home and they're diligent about doing their exercises, and that's one last thing I'd like to stress to everyone listening to this, either live or on replay, is don't own your clients' problems. Number one thing is you need to empower them that they have to go home and do work, man. They can't come into your sessions 2 hours a week and hope to fix these lifelong problems. They have to go home and do the work. So don't own this information. I mean, I should say own the information, educate and empower them, but they have to go home and do the work, and they should be doing them. You just tell them every day, because most of them are retired. What else do they have to do? They got to do their exercises. They brush their teeth every day. They got to do these exercises every day. Give them 3 exercises. Give them the footwork. give them the hip hinge, and then find one other exercise to do with them, give them 3 exercises to do, and then make them do them every day.
All right, final 2 questions. A couple people actually asking the same question. Any of your thoughts about working out in bare feet, barefoot training?
Love it. I mean, I really, I agree with Dr. Emily Spickle on this. I would get people in bare feet. Not everyone should be in bare feet, absolutely. And not everybody should be moving in bare feet. You can do barefoot work and just have clients stand there and start to get a sense of their feet on the floor and balancing on their feet, just standing there. They don't need to move in barefoot. So what we had with Jackie's clients, I mean, we do this with our own clients, but in Jackie's group, when I was down there, we had them all take their shoes off, do balance, feel their feet on the floor, do their footwork, stand back up, feel their balance, check their balance afterwards. Everybody noticed the difference. Put your shoes on, let's go to work. So it's not like they're doing the whole exercise class in bare feet, but I really feel the importance of doing some barefoot work as long as the client's doctor has not said, oh, don't do any barefoot work. They got to be in orthotics 24/7. Those clients obviously keep their shoes on. However, I would really spend a couple minutes in the beginning of your session getting your clients in their bare feet so they really get a sense of, even clients with diabetic neuropathy, same thing. Because even though they can't feel their foot, have them just do that work around the ball. You're mobilizing the joint capsules. You're sending some signals back to the brain, even though they may not be able to tactily feel the bottom of their foot because of either diabetic neuropathy or neuropathy due to spinal stenosis.
Okay, cool. All right. Last question. What do you do to stretch out the rigid foot?
That's the footwork. Put your foot on the ball, and that's why I said don't just roll like this. Find a spot and let the foot mold around the ball. Use different spots. You want to put the ball like this way. If this is the front of the foot, mold the foot around the ball. And then when you have the client stand up, and this is why barefoot work is so important, you want the client to feel as if they're going longer and wider, sending their toes long as they're squatting. Rigid feet need to do barefoot work for part of their workout. Otherwise, a lot of shoes, and they probably need more minimal shoes to work out in versus like a heavy orthotic type shoe, like a running shoe, a very supportive running shoe. Have them use more minimal shoes during their workout. That they will also be beneficial for the more rigid, stiff foot.
All right, last question. We probably need Janice on for this one, but someone from I'm guessing they're from Norway, and I'm not sure if it's Janika or Janika is asking, will you come to Norway in 2020 or at least Europe?
We are, we're having a course. We're planning a course in England next year. So yes, reach out to us through this contact. We will definitely, if there's interest, we can always piggyback a trip over there. If you have an interested group, feel free to reach out. Janice can obviously answer that and set that up for next year as well.
Yeah, great. We need to have Celia get you the contact that we've got in Norway, because Cody was in Norway, I think, last year. So,
was he?
Yeah, there's a university event. They had him over, and so just be careful. Just be careful what time of year you choose.
Okay. maybe in 2021 we'll have a functional aging summit over in Europe or something.
Yeah, there you go. There you go. Well, Evan, thanks so much for your time and how much you're doing for the industry. If folks are on the recording, I'm sure they're dying to ask you a question. So reach out to us directly. Contact at Functional Aging Institute. We can put you in contact with Evan and Janice and their company as well. We want to get your questions answered. So thanks again, Evan.
Thank you so much. Have a great day.